Occupational English Test, Practice Test, Listening Test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. This is a Benchmark Education Solutions Sample Test Paper. Extract 1. Questions 1 to 12. You hear a GP talking to a patient named Alex Summers about a skin problem. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mr. Summers. How are you today?
I'm doing okay. Thanks for asking. You can call me Alex.
Okay, Alex. So, what do we have today? I see you made the appointment for lesions on your hands. Is that correct?
Yeah, I kept thinking that they would go away, but that hasn't happened so far. Also, this isn't the first time this has happened, so I figured I should get it looked at.
Yes. So how long has it been since this latest outbreak of lesions started?
About 5 days ago.
I see. Any change in diet or medication?
Yes, I took ibuprofen for a fever about 12 hours before the lesions appeared.
So you mentioned having had these lesions before. Did you also take ibuprofen before that time?
Yes, I was taking ibuprofen for 3 days before the lesions appeared.
And did those lesions appear on your hands as well?
Yeah, same location. That time the lesions healed after a few weeks, but there was a little bit of a mark left.
Yes, I can see the residual hyperpigmentation. Did the lesions hurt at all?
Yes, there is a bit of a burning sensation.
Okay. Have you ever had any adverse reactions to other medications?
Not that I can think of. Do you think it's definitely related to the ibuprofen?
That seems like the most likely explanation. We will have to confirm, but I suspect that you have what is called a fixed drug eruption, which is a common immune-mediated mucocutaneous reaction to the consumption of a variety of different medications, including ibuprofen. Many patients forget about having taken over-the-counter drugs, which makes diagnosis more difficult. So it is good that you have kept track of what you have taken. It definitely makes my job easier.
Yes, I am usually quite careful about what medication I take. So you said something about confirming the diagnosis. What would that involve?
There are 2 possibilities. The more invasive approach is to do a small punch biopsy to examine the epidermis and apodermis. This would have been the best option if you hadn't told me about your medication history, or if you had an unusual presentation. The less invasive approach is a provocation test, which would use an oral challenge to check for lesion recurrence. Since you're fairly certain that you've only had a reaction to one medication, it should be relatively easy to confirm the medication responsible for your condition.
Sounds pretty straightforward. So, what about treatment? I mean, the lesions do seem to go away eventually on their own, but is there anything that can be done to help them heal faster?
Yes. Since your lesions are in non-mucosal areas, we can use a topical corticosteroid therapy, as well as an oral antihistamine, which should reduce the burning associated with the active lesions. Also, of course, once we confirm ibuprofen as the cause of your fixed drug eruption, we will find an alternative medication for fever management.
So anything else I should be on the lookout for?
Yes, people with fixed drug eruptions tend to be triggered by more than one medication, so I advise you to closely monitor how you react to any medications you take, in particular antibiotics, NSAIDs, analgesics such as acetaminophen, antifungal agents, uric acid reducers, and omeprazole.
So this condition is definitely something I should bring up whenever I'm prescribed a new medication.
Yes, that is certainly the case. It would be important information for any physician treating you.
This is a benchmark education solution sample test paper. Extract 2, questions 13 to 24. You hear a physician in the A&E talking to a patient experiencing abdominal pain. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mrs. Havison, my name is Dr. Cross. I'm a specialist in emergency radiology. It is nice to meet you.
Hello, Dr. Cross. It's nice to meet you. So, do you have an explanation for what is causing my stomach pain?
I think that I do, but before that, I want to confirm a few details about your medical history and current condition. So, according to your chart, you have been experiencing abdominal pain for a week. Is that correct?
That's right. I went to my GP 2 days ago and he prescribed me ranitidine, but that hasn't helped at all. I'm still in pain and feeling nauseous, and now I've started vomiting and feel bloated.
Have you experienced any pain after eating?
No, the pain does not seem to be related to eating. It has been pretty constant over this last week.
Okay, and you have diabetes?
Yes, I was diagnosed several years back. I take glyburide for my diabetes.
And now to your current condition. The first physician who attended you noted some mild tenderness in the mid-epigastrium and right upper and lower quadrants. Also, I just got your blood test results back, and everything was normal, aside from your blood glucose level. I have examined your radiography, and it appears that you have what is called a gallstone ileus, which is a type of mechanical small bowel obstruction.
I have gallstones, is that what you're saying?
Yes, in your case, because of chronic cholecystitis, which caused an inflammatory fistula, the gallstone was expelled into the intestine and got lodged in an area of intestinal narrowing, causing bowel obstruction. Your radiography indicates that the gallstone is quite large, about 3 centimetres in diameter.
Oh my, does this happen a lot?
No, actually it's quite rare. Gallstones cause less than 1% of bowel obstructions, but I do have to tell you that it is a disease of the elderly, so your age played a role in the development of this condition.
Well, at this age, everything stops working correctly. So what does this mean now? Will I need surgery?
Yes, you will. First, we will want to get your fluid and electrolyte imbalances taken care of. This condition is also often a sign of the condition I mentioned, chronic cholecystitis, which we will have to consider as we decide on your treatment plan. This condition can cause chronic inflammation and, as a result, the gallbladder could rupture, which would be a serious medical emergency. For this reason, removal of the gallbladder is a common course of treatment.
Okay, so what are the possible side effects of taking out my gallbladder?
Well, that depends on...
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a conversation between a physician and patient about pain management. Now read the question. This is a benchmark education solutions sample test paper.
So, Mrs. Mellows, you have been doing quite well on your regimen for the past several weeks, but now your pain has returned.
Yes, and they have tried a couple of things since I was admitted to the hospital, but nothing seems to work.
Yes, continuous subcutaneous infusion of morphine, as well as a patient-controlled anesthesia of morphine sulfate infusion. I want to talk to you about your wishes if your pain should continue to get worse.
Okay. I talked a bit with my family about this. So, no feeding tube or heroic life-prolonging measures like intubation or ventilation.
Okay, so...
Question 26. You hear a trainee doctor asking a senior doctor about a radiography. Now read the question.
Dr. Jones, can I ask you a question about the classification system to use for this ankle injury?
Yes, of course. So what do we have here?
It is an X-ray of bimalleolar fracture. The patient twisted her ankle getting out of a car. I was reading the other day that there are many fracture classification systems, so I was wondering which one is the most useful in terms of treatment.
Well, the name you just used for this fracture, bimalleolar fracture, refers to the number of fractures about the ankle. It is quite straightforward, but as you suspect, it is not relevant to the mechanism of injury or treatment. Another classification that you can use includes the mechanical forces responsible for the ankle injuries.
Question 27. You hear a nurse talking to another nurse about a patient's treatment. Now read the question.
Hello, George. I wanted to ask you something about something I noticed in Mr. Harris's file. You know, the newly diagnosed insulin-dependent diabetic admitted with pneumonia?
Okay, yes, I know which patient you're referring to.
I noticed that you did not record the patient's blood glucose levels prior to each meal yesterday.
Yes, his blood glucose levels have been the same since he came in, so I decided to save him a few finger pokes.
Well, that is a risk to client safety, and also it goes against the physician order to check glucose prior to each meal. I am concerned about you not following the physician's order and that client safety might be at risk on other shifts you work.
Question 28. You hear part of a training on infection prevention and control. Now read the question.
due to an alarming number of patients presenting with gastrointestinal illness over the last 24 hours, we wanted to review our infection prevention and control program. I know that some of you recently went through this training, but it is always good to review. The first part is to practice the 4 moments of hand hygiene as outlined in department guidelines. Please review these guidelines at the end of this meeting. Also, you must use appropriate personal protective equipment, such as gloves, gown, mask, shield, glasses or goggles. Next, be sure that you're implementing environmental infection control strategies to reduce the transmission of microorganisms, like sharps disposal, cleaning protocols for environment and equipment, ventilation, etc. Finally, we also need to make sure we are following standards and manufacturers' guidelines related to safe use, cleaning, disinfection and sterilization of medical devices. So, are there any...
Question 29. You hear a trainee nurse asking a senior nurse for advice. Now read the question.
Lee, I wanted to ask if the ward is always this busy. I have noticed that the nurse in charge asks for volunteers to stay almost every night because of a sick call.
It has been particularly bad lately. We have been working 1 nurse short for what seems like a few weeks, which means we are all very stressed from being short-staffed and working overtime.
How do you handle those situations? How do you balance patient safety and your own well-being with the needs of the ward?
You have to remember that your patient's safety and well-being is your primary concern, and also that you are accountable for your decisions and actions, including determining whether you can continue to practice safely. In our situation, there might not be an ideal solution, but there might be some different options to consider, such as...
Question 30. You hear a conversation between a patient and a dietitian. Now read the question.
So, Mrs. Fellows, you were referred by your GP for pre-diabetes.
Yes. I was identified as having pre-diabetes 8 months ago, and I've been trying to lose weight on my own, but without much success. That's why I'm here today.
I see. So your initial assessment indicated that you have a BMI of 29 kilograms per metre squared. A BMI over 25 kilograms per metre squared is a risk factor for diabetes. So what changes have you made to your diet over the past 8 months?
Well, none really. I started doing some exercise, walking with a group of people in my neighbourhood 5 times a week for about 45 minutes each time. But I've not been so successful at eating less fat to lower my cholesterol.
I'm going to recommend that you...
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear part of a training about the use of radiology in patients with headache. You now have 90 seconds to read questions 31 to 36. This is a benchmark education solution sample test paper.
Hello everyone. Thank you for attending today's introductory training in emergency radiology, which is a subspecialty of diagnostic radiology. The target audience of today's training is for trainee A&E physicians, as you will be the emergency radiologist link to the patient and the one who generally refers patients to an emergency radiologist for a CT scan or MRI. As you're all aware, emergency diagnostic radiologists are an integral part of a hospital's emergency team, and so the better we work together, the better the outcomes we can get for our patients. So today we hope to give you a bit of insight into the types of conditions we can treat. The topic of today's presentation is how to read a head CT in patients presenting with headache. So, first of all, a thorough review of each CT slice for its anatomical landmarks should be conducted and, in addition to this, an organized search for signs of various disorders that can cause headache should be carried out. These disorders include aneurysmal subarachnoid hemorrhage or intracranial mass such as tumor, abscess, or an intracerebral or subdural hematoma, arteriovenous malformation, cerebral venous sinus thrombosis, and sinusitis. The first step in this organized search is to compare the left and right cerebral hemispheres for symmetry and to look for midline shift indicative of an intracranial mass. A midline shift of more than 5 mm will require emergency surgery, while a more conservative approach can be taken with patients presenting with less than 5 mm and who are alert and neurologically intact. The next step is to examine the basilar cistons for evidence of subarachnoid hemorrhage, which is a life-threatening type of stroke caused by bleeding into the space surrounding the brain. A symptom that patients diagnosed with SAH often report is the sudden onset of the worst headache of their lives. Treatment for SAH depends on its cause, such as a ruptured aneurysm, which would likely require surgery to stop the bleeding. The third step is to examine the ventricles, as ventricular enlargement may represent an obstructive hydrocephalus due to a mass-causing obstruction to cerebrospinal fluid, a clear fluid that surrounds the brain and spinal cord. Symptoms would include headaches, double vision, and poor balance, among others. This type of problem would result in one or two ventricles becoming enlarged. On the other hand, the enlargement of all four ventricles of the brain is associated with SAH and meningitis, or may be due to a chronic condition. Next, it is necessary to examine the brain's parenchyma, which refers to the functional tissue in the brain that is made up of two types of brain cells, neurons and glial cells, for anatomical distortion that is indicative of a mass lesion, bleed, or vascular malformation. The fifth and sixth steps include the examination of the sinuses. First, the major cerebral venous sinuses, particularly the superior sagittal sinus and transverse sinuses, should be examined for hyperdensity, which would be indicative of thrombosis, which is the formation of a blood clot within a blood vessel. Next, the paranasal sinuses should be examined for signs of sinusitis, which is the inflammation of swelling of the tissue lining the sinuses. Symptoms of sinusitis include severe headaches and double vision. The initial diagnostic test in the evaluation of A&E patients that present with headache is generally a non-contrast CT. As physicians in the A&E, you may have to make the decision to order a scan for a patient presenting with severe headaches. In most cases, a CT is not necessary, as the source of most headaches can be determined by a careful examination of medical history and a neurological exam. Here are the cases in which it would be necessary to order a CT scan or an MRI for a patient presenting with severe headache. First, if the patient is having a sudden onset of headaches or feels like something is bursting inside his or her head, a CT may be needed. In addition, if a patient reports a change in the types of headache he or she is experiencing, especially if the patient is over the age of 50, a CT may be necessary. Another reason to order a CT would be if the patient reports having headaches with other serious symptoms, such as loss of control, a seizure or a fit, or a change in speech or alertness.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear an interview with a dietitian about malnutrition in the elderly. You now have 90 seconds to read questions 37 to 42.
Hello everyone, I want to welcome you all today to this interesting conversation on tackling the wider aspects of malnutrition in the elderly. Jasmine Patch is with us today. Jasmine is a specialised dietitian and she is currently working on the malnutrition project for a local hospital.
Thanks very much for that introduction.
So, Jasmine, why don't you start with a bit of background about malnutrition in elderly and the project you are currently working on?
I would love to. So, malnutrition is multifactorial and often means that dietetic interventions require a multidisciplinary approach. In response to this, the Malnutrition Project was set up to help manage a caseload of housebound adults who are at risk of or have malnutrition.
So, can you tell us about a typical case to help us understand the project and its unique approach?
Yes, of course. So, I'm going to talk a bit about a case study that, whilst fictional, is based on a typical patient seen by our team. So, Mrs. Thomas was referred by a speech and language therapist for poor oral intake and significant weight loss, over 12 kilograms in about 10 weeks. Once we received the referral, the patient's care agency was contacted through social services. This was so we could arrange for the dietitian and carer to be at the patient's home at the same time.
So, in this type of case, what are the barriers to optimal nutritional intake?
Well, the first is a reliance on others for food and drink. Older patients often depend on others to prepare their meals, so they do not have free access to food and drink. Another barrier is social isolation. In this case, the patient expressed feelings of loneliness and said that she would appreciate company while she eats. There are other barriers related to her medical condition, such as swallowing issues and poor appetite, but the social barriers play a key role.
So, what kind of plan can be put together for elderly patients suffering from malnutrition?
In this case, we put together a plan to promote weight gain by optimising nutritional intake of calories and protein. We also wanted to ensure that the patient was provided the appropriate texture of food, as it was something she commented on during our initial assessment. The plan included using full-fat milk to make porridge and drinks, and swapping from digestive biscuits to all-butter shortbread biscuits. Another part of the plan was to offer milky pudding after meals, such as rice pudding and yoghurt. Finally, we involved the carers by having them keep food and fluid charts.
So you mentioned at the beginning of our interview that you take a multidisciplinary approach. How would that approach be applied in this type of situation?
Well, first of all, the patient was eating soft, ready meals prior to intervention, and during our initial assessment, she said that she did not like the texture of the meal and also that she had not had any recent choking or difficulty with swallowing during or after eating a meal. So we worked with the speech and language therapist that originally referred us to see if the patient could be upgraded to a more normal food texture with the objective of improving her oral intake. We also worked with her existing social service provider to review her nutritional needs. In particular, we requested that the carers be allowed more time to prepare lunch during the morning visit. We also started to work with what is called a befriending service to have someone eat meals with Mrs. Thomas, which helped mood and therefore nutritional intake.
And would you say that the project has been a success so far?
Yes, I most certainly would. In the case of Mrs. Thomas, she gained about 10 kilograms in 10 weeks. The befriending service had a huge impact on her mood and appetite. We are still working on getting her a swallow assessment so that she no longer has to eat the same texture modified meals that she dislikes. Also, we're working on adjusting the dietary supplement she was originally prescribed.
So, what have you learned from this project?
Well, one thing we have learned is how to follow a food-first approach for weight gain, as we are working with patients who often have fixed incomes, so we need to make sure our plan is cost-effective. We've also faced the challenges that come with accessing a patient's home, which we have overcome by liaising with social services, district nurses, and care agencies.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.